Okay. So I'm really excited to be moving on from diarrhea. It feels like that was a really, yay. It was a really long time in the gastrointestinal pancreas liver section. So we're moving on to the endocrine section. And I was looking at the sort of list of topics. This will probably take us up to pretty much Christmas. And then there's repro, which I'm going to condense the 8 chapters into like one session because it's way too boring. And then in the new year, we're going to start on renal disease. So we'll do a proper like physiology one and then move into actual sort of diseases and management stuff. So way more interesting than the last few months. The first thing I want to talk about is basically a really clinical version of calcium physiology and homeostasis as much as we can, and bringing the names of the different hormones in and getting people comfortable with kind of talking about what does what. And then we'll start talking about that in relation to the different conditions that we see clinically as well. So I'm going to make you do a lot of the talking as usual, Josh.
Fine.
Good. Okay, tell me about how calcium exists in the body. Where is it?
Me. So calcium, there is unbound and bound calcium in the extracellular space. I think about 50% is bound to protein, so mostly albumin. I think about 40% is unbound, and then there's like another 10% somewhere else.
Yeah.
Well, yeah. 50%
ionized, 40% bound.
Oh, okay.
Where would the other 10% be?
I figured in cells, but or
bones.
Where?
Yes.
In the bones.
Yeah.
Oh, in the bones. Okay.
I'm surprised there's only 10% though, actually. Excuse me, sorry.
Yeah.
I don't remember,
but maybe that's not
the other way around. I think it's the other way around.
Well, no, it's what I've got in my notes. So 10% is complex with bicarb and other ions is what I've got in my notes.
Yeah,
but
that's right.
I'm assuming that like calcium carbonate is bone, right? So that's a complex. So I guess it's in only 10% in the bones. That's surprising. Good. I'm glad we've resolved that. So what is the significance of the 40% that's protein bound?
It's it's affected by albumin concentration. So if albumin goes up, then your total calcium will go up.
Excellent. So how do we want to, when we're wanting to measure the sort of significance of calcium, what do we want to measure?
Yeah, ionized calcium.
Perfect. Yeah, because total calcium is just...
And quickly, as quick as possible.
Why? Tell me more.
It's just so affected by other things. So I think if it's sitting in like EDTA or with red blood cells, it can. Oh wait, I get confused all the time. I think it goes up, but then with oxygen it goes down, or it's the other way around. It's one of those.
So I had to write this down to get it clear in my head. Let's go through the different artifacts which might impact our ionized calcium measurement. So you mentioned EDTA, Josh. What will EDTA do to calcium?
I think it chelates it, I think. So it decreases calcium.
Good. Yeah, good. There was a few people that knew the answer to that.
Oh, sorry.
Yeah, that's good. Exactly right. So what does that mean?
I think it binds to it and takes it out.
Exactly. So you can't measure it once it's bound. So if you try and measure ionized calcium on an EDTA sample, you get a really, really low, if detectable, measurement.
Can I say something there that blew my mind when I was studying calcium homeostasis eons ago, before you were born, Josh? That calcium, like you go through the clotting cascade and there's no number 4. It's calcium.
No way.
And so yes, and that's why we use EDTA to chill out the calcium so it doesn't clot. Ta-da!
Wow, that's really cool.
How cool is that?
Can I just say, I did 7 years of a PhD in coagulation. I've never heard calcium referred to as factor 4. That is amazing.
Well,
but it's exactly right.
I can't remember where I read it, but it blew my mind.
I'm sure you're right, because but it doesn't fit in the cascade because it's a cofactor in every single reaction that happens in that cascade. So blood can't clot if there's not calcium in every single one of those reactions. So if you take it out, then the EDTA stays unclotted. So it's a really good point. Okay, and that's the same for citrate that we use in coag samples.
It's a single organ with sedation.
I'm just gonna. There we go. What other things might cause artifacts? Josh, you mentioned red cells storage.
Yeah, red cells. Maybe they decrease calcium as well. I can't. Yeah, okay. It increases it, and then oxygen exposure decreases it. So
yes, excellent. Yeah. So let's talk about the red cells. What do cells do when they're utilizing energy and they've run out of oxygen? So you're in a closed tube and there's no oxygen in there. What will they produce?
Lactate.
Yes, good. Which will do what to pH?
Decrease the pH.
Which causes what to happen to ionized calcium?
Go up.
Good, exactly. So acidity will increase ionized calcium. So it's nice clinically to have that in the back of your mind as well. So where the curve's sort of shifting with your acid base. And then exposure to air. Rather than losing oxygen, it's actually carbon dioxide that you lose. So what will that do to pH? What's carbon dioxide, acid or base?
Acidic.
Acid.
Good. So if you lose CO2, what's your pH going to do?
Go up.
Go up. And what's your ionized calcium going to do?
Go down.
Yay.
Makes
Excellent.
sense.
Good.
Yeah.
And what about a patient with hypoalbuminemia? What will we see on our total calcium?
Low.
So what will we see on our ionized calcium?
Should be whatever it, like normal, whatever it is.
Yeah, perfect. Exactly. So if you've got a low ionized calcium in a hypoalbuminemic patient, they're probably losing it somewhere. Any other artifacts we see with calcium?
Yeah, like lipid increases
Good.
calcium.
Yep.
I think hemolysis does as well. Increases calcium.
Very good. Excellent. Okay, we've covered all of the causes of spurious abnormal calcium findings. So now when you see an abnormal calcium finding, you'll go, are they, what's the word? Acidotic? That's the word. Acidemic? Are they alkalemic? Is there lipemia? Is there hemolysis? Did I use the right tube? And you'll be able to ask all those questions. Did the sample sit around for too long? Now let's talk about what controls calcium. What hormones have an impact on calcium homeostasis?
I'm happy to do it, but maybe someone else should have a go. So.
It's not the Josh show.
No, definitely not.
Parathyroid.
Good, excellent. So we'll just list the hormones for the moment and then we'll go into what functions they have. How many are there? I shouldn't say hormones because they're not all hormones.
Vitamin D.
Good, yeah. One more?
Calcitonin.
Yeah, very good, excellent. And then there's one more that we can measure sometimes, particularly in neoplastic disorders. What is that?
The protein, PHR, the parathyroid
Yes.
protein.
Yeah, related protein. That's right. Related peptide. So what does PTH, I gave away the answer. Sorry. What's the most important hormone? What's the one that has the biggest impact on calcium homeostasis? PTH, exactly. Yeah, so that's by far the most influential of the hormones. So say I've just had a meal and I've absorbed a lot of calcium. What's that going to do? How does that then impact my PTH level if you were to measure my PTH?
If your calcium goes up, it's going to feed back negatively onto your parathyroid. So I think there's calcium sensing receptors. And once it detects that, it decreases the amount of parathyroid hormone synthesis and release, I think. So, but yeah, because parathyroid hormone is the biggest factor there, that's kind of the main thing that changes.
Yeah.
I think it also increases calcitonin release, but only in small amounts. So it's less effective. So.
Yeah, that's exactly right. I'm going to leave out, I'm going to come back to calcitonin just so that we're kind of considering them separately and we can have it really clearly. But what Josh said about the calcium sensing receptor, I remember Karina Graham, actually, I'll just do a little shout out. She wrote a paper in the AVJ in 2012, which goes through calcium homeostasis so well. And I did my training with her at North Shore, and her research project was measuring PTH intraoperatively where in dogs with hyperparathyroidism, but when people were manipulating the parathyroids and correlating that with the ionized calcium, and then immediately post-operatively, so you could see that they'd got the right parathyroid out by documenting that the PTH level just dropped through the floor. Because obviously when one gland is overproducing, the other glands suppress it. So it's a really interesting research project. She did this big review on calcium homeostasis. And then she explained it to me. It was 2 years behind her in training. And I remember her going into this huge amount of detail of what the calcium sensing receptor looked like and the fact that it's a transmembrane receptor and this and that. And I was like, seems like you've just gone down a little rabbit hole and is never going to be relevant. And now I want to tell you all about the calcium sensing receptor. I won't bore you, but it's a really interesting receptor in the way that it works. So the calcium sensed by the receptor, and then if we've got high calcium, we need less PTH. So what about if we've got a little bit of diuresis, increased calciuria, and our calcium level drops? How's that going to impact our PTH level?
It'll increase PTH. Again, by feeding back those receptors will increase parathyroid hormone synthesis and release.
Good. Okay. And so you've released parathyroid hormone. Where is it going to be effective?
It's going to be effective in 3 locations.
Good.
So it will be effective in targeting the bones. It increases osteoclastic activity, so breaks down bone calcium and puts it into the blood. It also works on the kidneys by it hydroxylates vitamin D into its active form. Good. Calcitriol.
Yeah.
Which then increases gastrointestinal uptake.
Yeah.
And it also works on the kidney as well to decrease loss in the, I think in the distal convoluted tubule and also somewhere else. I can't remember where.
This is amazing, Josh. Did you study this for today? Like, is this fresh in your mind, or is this your basic knowledge?
No, because it always comes up. Like, we see a lot of calcium things and have to decide whether it's real or not. And I remember studying it really hard for membership, and this is one thing I think that's stuck.
Well done. The one thing I'll add to that is that there's 2 sort of phases of effects of PTH on the bones. When you get an acute spike of PTH, like a sudden drop in calcium, it releases the calcium from the extracellular matrix rather than increasing osteoclastic activity. So it just kind of releases that stored calcium, which is needed quickly. And then if you get chronic PTH elevation, that's when you start to get the increase in osteoclastic activity and bone breakdown. So the calcium that's stored in the bones is like the reserve of the reserve. So the extracellular matrix, number 1 reserve, and then in the actual mineralized bone is like the last resort for sourcing calcium. And now we talked a little bit about the impact of PTH on activation or hydroxylation of vitamin D. Let's talk about vitamin D, but I want to go back a step in where does vitamin D come from in most of our companion animals?
Diet.
Yeah, exactly. Yeah, that's definitely a Matt question.
Should come from the diet, but often there's not enough.
Yeah. And then where does it go? How is it processed in the body? So what form of vitamin D is absorbed from the gut?
25 OHD.
It's not 25 yet.
Oh, not one.
Yeah. So from the gut, you absorb cholecalciferol, which is just straight vitamin D. And then where's the first conversion happen? There's two conversions. The second one's in the kidney. Josh has mentioned that one. Where's the first one?
Skin involved, and then this cholesterol does something as well. Like skin. Is that
in humans?
Okay,
Skin is involved, but in dogs and cats, because they're furred, they can't have that reaction because the sun doesn't contact their skin. So the vast majority of vitamin D is from the diet rather than from the skin. And then which organ other than the kidney hydroxylates things?
Liver.
Yeah, exactly. Yeah, good. So you go.
Oh, sorry. Is it true that dogs and cats manufacture some vitamin D in their fur and can lick it off themselves from the sun?
Wow, I've never heard that, but I have to say I haven't researched it extensively.
Fair enough.
Yeah.
Just throwing that one out there.
Yeah, interesting. So you absorb cholecalciferol from the gut. Then in the liver, first pass, it gets hydroxylated to 25 OH cholecalciferol. And I'm probably going into too much detail, but when we say hydroxylation, it's adding a hydroxyl group, an OH group. And that 25 OH just describes where along the molecule that OH group was added. So at position 25. So we've got one hydroxyl group being added there. And then that is calcidiol as well. So you can call it 25 OH cholecalciferol, or you can call it calcidiol. And then you can go, it goes to the kidney, which Josh was talking about, and it gets another hydroxyl group. It's hydroxylated again to its active form, which is called
calcitriol.
Calcitriol, exactly. So we were diol before, now we're triol. And before that, we only had one. So what's this? Where's the second hydroxyl group? What's the other name for calcitriol or active vitamin D? There's 25 OH is calcidiol. What's calcitriol?
125.
125. Okay, so we've got hydroxyl groups at position 1 and position 25. So that's all that sort of means, because I think you get caught up trying to just remember these numbers that don't mean anything. But if you can then picture this like big long chain of molecule, and you picture an OH group there and an OH group there, it makes it a little bit easier to comprehend what those numbers mean. And if you're in an exam situation, for example, and they throw the name 125 OH vitamin D at you, you know it's the active form, as opposed to, you know, if they don't use the word calcium. Make sense?
It does. That's really cool. I pretty much almost failed organic chemistry, so it's
I didn't get it.
Nice to actually have something that makes sense.
Trick. Yeah.
Yeah, it's so boring until you're actually doing medicine, and then it's like, oh, significant. Yeah. Okay, so what in the liver, that first cholecalciferol to calcidiol conversion is unregulated. It just happens. Like every bit of cholecalciferol that comes through gets hydroxylated to calcidiol. The hydroxylation in the kidney is much more regulated. Josh mentioned that PTH impacts that. Can you tell us again what PTH, how PTH does that?
I don't actually know exactly how it does. I just know it does it.
It does that. Yeah. Does it increase vitamin D or does it decrease vitamin D?
Oh, it increases vitamin D.
Increases. Good. Yeah, excellent. So PTH will also increase vitamin D. So we've got then two kind of approaches to increasing our calcium levels. How does vitamin D increase calcium levels?
Through gut absorption.
Good. Excellent. That's pretty much it, isn't it? I think it decreases phosphorus excretion in the kidneys. And other than that, it only impacts the gut. It doesn't actually impact the calcium at the kidneys. Okay, what about calcitonin?
Can't remember if you taught me this, but I always remember it as calcitone it down. Sounds like something that you taught me.
It sounds like me, but I don't think it was. If it was, I made it up on the spot and I forgot it again immediately. Good. So what's that going to do to your calcium?
It decreases it. So it helps a little bit. But
yeah. I was just remembering who I might have, because we were talking about using calcitonin in a patient who had idiopathic hypercalcemia. Do you remember that one? We'd have used all of the permidronates and Dallas. Yeah, exactly. I could only remember the surname. I'm like, I shouldn't say that on here. Yes, so calcitonin is going to tone it down. Does it have a huge impact? Like if we have a hypercalcemic patient, do we regularly give them calcitonin? That would make sense, wouldn't it? No, not really. Yeah, it just does. It does very little, and the PTH will just sort of increase. If the body wants the calcium to be high for whatever reason, then it's just going to override the effect of the calcitonin. And if you like take out the parathyroid glands, no, wait. I'm not going to go down that road. Sorry. Okay. So what sort of diseases do we see where we get hypercalcemia?
Plasia.
We'll say again, sorry.
Neoplasia.
Neoplasia. Good. Okay. What's the mechanism of hypercalcemia with neoplasia?
Parathyroid related hormone.
Good.
Release. So it's paraneoplastic syndrome.
Most of the time, exactly. So we didn't talk about PTHRP and the impact it has and what organs it is effective on. Does anybody know?
What organs it's effective on?
How it sort of impacts calcium homeostasis?
I think it just...
I guess it would work on wherever PTH works on, because it's a related hormone, so it's mimicking it.
Exactly. Yeah. So exactly the same effects as PTH. I'm not going to go into too much detail on this. I get really excited about the different causes of hypercalcemia and malignancy. So PTHRP is one. What sort of malignancies do we see that in?
Lymphoma, perianal, anal sac carcinoma.
Good. Yeah. They're the big two.
Multiple myeloma.
Yeah.
Probably from, is that PTHRP or is that just hypercalcemia?
This is such a good question. I said I wasn't going to go too deep, but let's do it. So lymphocytes, T lymphocytes in particular, contain 1-alpha hydroxylase. Is that name familiar to any of you? No. So the mechanism that PTH converts vitamin D from calcidiol to calcitriol is 1-alpha hydroxylase. That's the regulated step. So PTH increases 1-alpha hydroxylase activity. Wait, does it decrease it? Because hydroxylase implies taking away a hydroxyl group. So maybe it either decreases or increases 1-alpha hydroxylase, but the effect is that it increases vitamin D. So if you've got more T lymphocytes, you've got unregulated stimulation of vitamin D production, and you end up with excess vitamin D.
Oh, wow.
Cool, hey?
That's cool.
So that's the other mechanism of hypercalcemia of malignancy, and it's seen almost exclusively in T cell lymphomas.
Wow.
Cool. The other ones that can produce PTHRP, there's a couple of other carcinomas like anal sac adenocarcinoma, same mechanism, mammary, pancreatic's reported, but pancreatic, they usually get sick and die before the tumour gets big enough to cause hypercalcemia. And there's been like a couple of lung tumours that have been reported to cause it. So say we had a hypercalcemic case with an anal sac mass. What blood tests are we going to do to work out whether the mass is causing the hypercalcemia?
Ionized calcium.
Good. It's high.
Parathyroid hormone, if possible.
Mm-hmm. What's it going to be?
Low.
Low. Good. Why?
Because the related peptide is going to be feeding back on that loop and suppressing production from the parathyroid gland, but there's obviously going to be rogue production of PTHRP still. So
yeah, so that's completely unregulated. So is it the parathyroid hormone related peptide feeding back on the parathyroid gland?
Yeah, I think so.
Directly?
I think so. Yeah.
Or is it the calcium?
Oh, sorry. The calcium. Sorry.
Good. Yeah. So that we've got the PTHRP causing the hypercalcemia. So that's going to suppress PTH production, which is a completely appropriate response. What other tests might you do?
I think you can test PTHRP in Australia, but in America you can.
You can, for sure. What's it going to be?
Really high.
Really high. Good. And what about if you were to look at the parathyroid glands, how would you look at a parathyroid gland?
Maybe MRI might be the best.
You can do ultrasound.
Yeah, good. I think ultrasound we do most commonly just because of availability. MRI would probably be a really good way of looking at it, but I have to say I've never seen it. Yeah, Alex, I might defer to Alex on this one.
I would have gone with ultrasound, but only because it was accessible.
Yeah.
We do the nuclear scintigraphy.
Yes.
If you had access to it.
Yes, good, excellent. How do you make a parathyroid gland stand out with nuclear scintigraphy?
Iodine.
Is it iodine? Parathyroid?
No.
Be with the thyroid.
That would be thyroid.
Yeah.
I don't know that.
I think it's called cystamoebe.
Oh,
we don't have that. So scintigraphy is definitely on the exam answer list for fellowship for sure, but it's not something that we do in Australia. It's really hard to get. I remember Karina looking into it as sort of part of that study, and it was just impossible. CT is one of the other ways we look at the parathyroid gland, but I've spoken to Sarah recently about this because I had a patient, because I work doing mobile ultrasound. Sometimes people sort of call you into doing an ultrasound and you're sort of like, oh, would I actually CT this if I had the option here? And in this patient, we actually were able to identify a parathyroid nodule on ultrasound, but I think it was kind of lucky. And when I talked to Sarah, she said, I always ultrasound first, and then if I can't see, go to CT, because CT is actually not that much better than ultrasound accuracy wise. So there's no great way to look at parathyroid glands. So say in this patient who had elevated PTHRP, low PTH, and we were able to accurately image the parathyroid glands, what would they look like?
Small, I imagine.
Small, yeah, good. Uniformly small. How big are they normally?
Very small.
Very small. So like between 1 and 2 millimeters is normal. And there's two that sit cranial to the thyroid, and they kind of stand out a little bit more. But there's the caudal two sit in the thyroid tissue, and you can't see them at all unless they're tumors, basically. And even when they're tumors, you're like, oh, is it? So in this situation, if you'd gone straight to sort of imaging parathyroid glands, it would have been a waste of a diagnostic test. Obviously, you want to ultrasound the abdomen in this patient to check for METs before kind of jumping into surgery, but this is a hypercalcemia of malignancy for sure. What other diseases cause hypercalcemia?
Granuloma.
Which one, sorry?
Granulomas.
Which one? Granulomas. Good, good. Okay, we're starting with the zebras.
Yeah, another hypoadenocorticism also causes.
Good. Does anybody have an acronym that they use for? Yeah.
It's hard goings
or something like that.
Hard goings, yeah. Hard goings.
or hard irons G.
Hard irons, yeah.
Same thing.
Hard what?
Or hard irons G, but I put the G in the middle, so it's hard goings.
At least that's a word.
I use gosh darn it.
Oh, I like that. Yeah.
Because it's calcium homeostasis is a real headache. I mean, it's interesting, but you're like, gosh darn it, I got to do calcium again.
Okay, so are these all, because gosh darn it sounds like a longer acronym than hard goings. Is it? Hard goings, gosh darn it. So let's go through. So G, let's do gosh
granulomatous.
Yes, good. Okay. We're going to use this acronym and we're going to just work through hypercalcemic using this acronym. And as we go through, you're going to tell us what they stand for.
Okay.
So let's talk about granulomatous disease. Oh, can I talk to you about granulomatous disease? I don't know if I know enough about it. Someone that studied memberships recently. We just don't see granulomatous disease in Australia. What causes granulomatous disease overseas, which causes hypercalcemia?
Would it be like different types of microcysts?
Yeah, fungal disease, exactly. We just don't really get them in Australia. We get fungal diseases, but not the ones that cause big granulomas in the lungs and extensive granulomatous disease.
What about FIP causing granulomas? Do any of you guys see hypercalcemia in your FIP cases?
Interesting.
I had one recently, but it had normal calcium. But it was only one of those like big ileocolic granuloma. There was no other granulomas.
Yeah. I'm asking the question, but I haven't seen it. But I often think, well, that's the only granuloma, or the most common granulomatous disease I see, but I don't see the calcium associated.
No. And I don't, typically we don't see huge granulomas in FIP, do we? Like they're usually pretty small and widespread. And that case Josh is referring to had just the single granuloma. That's quite a rare presentation, I would say.
Could it be more, I just remembering back from uni days, granulomas often on a histopathology level, they had like calcium deposits through it. So I wonder if there's something to do with the cells in there producing more calcium, like metastatic hypercalcemia or whatever it's called. I can't remember.
I'm Googling because now I'm really interested.
A while now, so I don't remember.
Yeah. Oh God. My search terms have yielded a very that 1-alpha hydroxylase enzyme is in macrophages as well.
Hey,
there you go.
Interesting. So then do we see mineralization? When we see mineralization in a mass lesion, or mineralization where it's not dystrophic mineralization where it doesn't belong, it's either associated with hypercalcemia or inflammation. So we see it quite commonly associated with carcinomas, which are more inflammatory tumors than like sarcomas typically are. And then I would assume it's the same mechanism in a granuloma, that it's inflammation causing that, which is then exacerbated by increased vitamin D causing a systemic hypercalcemia. So we've got more calcium and we've got inflammation, and therefore it's going to get deposited there. Make sense?
There's also granulating stimulating factor and macrophage activating factor has to do with vitamin D as well. So within a granuloma or a neoplasia, that might be part of the mechanism.
Interesting. So it has to do with vitamin D in that they kind of like positive feedback each other.
There's something about how the macrophage is like presented to using these factors. That's part of the cascade of the immunity.
Yeah.
I don't know more.
Okay. Did you just Google
Something
that,
like
or did you know that?
No, I knew that because there's some cancer treatments that use that mechanism.
Oh, I'm glad we've got to the bottom of that. So if we were to then test for the cause of hypercalcemia in this patient with, we know it's granulomatous disease, but we didn't when it came in, what's the ionized calcium going to be?
Elevated.
Yeah. What's the PTH going to be?
Low.
Low. What's the vitamin D going to be? If you could measure it.
High, I guess.
High.
Yeah.
Good. Yeah. What are the parathyroids going to look like?
Small.
Small. Good. Diffusely small. Excellent. All right. Gosh darn it. Oh. What's those?
Osteolytic.
Osteolytic disease. Good. Ooh, what's the ionized calcium going to be?
High.
High.
We're doing hypercalcemia, so they're all going high.
I was like, is that a trick question?
Sorry. We're gonna get to diseases that don't have high. I remember. Oh, what time is it? My watch is telling me. No, it's not. Don't worry. Telling me what time sunset is, and I'm like, it's not 5:51 in the afternoon. What causes osteolytic diseases?
Osteosarcoma.
Sarcoma. Yeah. Good. Has anybody ever seen hypercalcemia associated with an osteosarcoma?
No.
No. The body's so good at regulating. So we might have a bit of increased calcium and the body's just going to say, okay, or I might just secrete a little bit less PTH as a result of this. So it's very uncommon for it to actually cause hypercalcemia. I can't think of any, I mean, theoretically it's possible, but I think very unlikely. Gosh, what's this?
S.
Furious.
Furious.
Good.
Yeah.
We've already talked about those spurious causes of hypercalcemia, and they're really common. So always check yourself, check your methodology. H.
Boy.
Yeah. Primary
Hyperparathyroidism.
hyperparathyroidism.
Good. Excellent. What causes hyperparathyroidism?
I think it's like a small benign tumor, normally like a adenoma.
Excellent. Yeah.
Or secondary renal.
Renal disease.
Yes. Good. And
Nutritional.
Iatrogenic vitamin D excess.
good. So would that be classified as nutritional? Hypervitamin, like the nutritional
secondary
vitamin D?
hyperparathyroidism.
Well, that's the D in Darnett.
That's vitamin D toxicosis.
Oh,
But
okay.
this is so nutritional secondary hyperparathyroidism.
Oh, that's phosphate.
That's phosphate. Tell
Also.
me more.
In-
How does that cause hyperparathyroidism?
That's fun, isn't it?
I'm so glad we got here.
I find that,
Don't we all?
it's so frustrating.
Oh, was that sarcasm?
So this is way more interesting and is going to test your calcium homeostasis knowledge than primary hyperparathyroidism, which is really boring. So let's go down the nutritional road. So let's talk about the test. So what is nutritional secondary hyperparathyroidism?
Like diet's low in calcium. So there's less calcium being absorbed. So the parathyroid hormone kind of will kicks in because it's hypocalcemia.
Mm-hmm.
And then I think it just kind of keeps winding itself up, trying to get more calcium, but because there's no calcium from the diet, it just never kind of gets there.
Mm-hmm.
Often it's low calcium, low to normal, I think, inappropriately normal.
Yes, good, excellent. So the body, I mean, there's big stores of calcium in the bones. The body will work really hard to normalize the calcium. So this is one calcium disease. What's the ionized calcium going to be?
Yeah, normal.
Low or normal? Yeah, exactly. Often normal, actually. What's the phosphate?
Increased, I think. No.
Low. Often low.
Oh.
What's the PTH going to be?
High.
High. What's the parathyroid going to look like when we look at it?
Huge.
Did you say
Huge.
enlarged? Yeah. Uniformly, like all four enlarged, or yes, good, excellent. So diffuse enlargement of all of the glands rather than a single nodule. Because if you were doing assays, obviously you don't have a hypercalcemia, so you're probably not looking for a primary hyperparathyroidism. But so how are these patients going to present?
Weak bones.
Weak bones.
Yeah.
What are the other differentials of that?
Renal related.
Good. Yeah. Mm-hmm. How are you going to differentiate them?
Bloods.
Dietary history.
Yeah. Good. Yeah.
And then you look at the phosphate, I think, because with renal, the phosphate should be high.
Yeah. And what else on your blood tests?
Azotemia.
Yeah. Yeah. This is we only see renal secondary hyperparathyroidism being clinical and causing weak bones when they've been profoundly azotemic for a really, 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 really long time. So the only time, I've got a story for you.
Oh.
It's terrible. I had a dog come in status once, and the owners were like, it's been a normal dog up until today. 2-year-old beagle, I think, a young dog. And we were like, oh, it's gotten into something, of course, like pattern recognition. And I went to tube it, and when I went to open its jaw folded down like that. It was like the proper rubber jaw. And this dog had a creatinine. It had a creatinine of 2000 when I saw it. God knows what it had been for long. And looking at its kidneys on ultrasound, they were just so dysplastic. And he'd obviously had congenital renal dysplasia and had been in renal failure his whole life. So the owners knew no different. But it was like such profound impact on the brain. So that I think that's probably the only situation you're ever going to see renal secondary hyperparathyroidism without clinical signs of renal disease. But even like the azotemia is there. So you won't get confused between renal and nutritional. When we look at the bones impacted by nutritional versus renal, does anyone know the difference?
Yeah, the nutritional tends to be appendicular skeleton.
Yes.
Whereas renal tends to be like the skull and
yes
area which the radiographs like the bones are affected. Yeah.
Yes, exactly. So you'll see it more like on a radiograph, just because it's really hard to assess skull density on a radiograph, because like staffies will be really dense. Chihuahuas not so much. But you'll see it in the jaw bones mostly in renal, and sometimes along the spine, like the spinous process will be harder to see. Whereas nutritional secondary tends to affect the long bones, like that's where it's most obvious on radiographs. So knowing that, what's the more common clinical sign of nutritional secondary hyperparathyroidism with regards to bones?
Fractures?
Yeah, exactly. Pathologic fractures.
Okay.
What's the sort
That's
of fracture they get?
With all the poorly kept reptiles, right? They all people who are keeping appropriately, and they all have bone fractures of their limbs.
Really?
They're just not getting enough calcium and vitamin D is part of their problem.
Yeah.
I've definitely had things like chameleons have broken legs from it.
That's well outside of my.
I'm definitely no reptile doctor, but somebody left me a chameleon once to care for 3 years.
Oh, wow.
And definitely had like pathological old leg fractures.
Wow. I'm going to need to
So
talk to Izzy about
think
this.
they all have secondary nutritional is
Yeah.
the problem with their
Poor
calcium.
diet.
And no
Yeah.
labs.
And no lamps.
Yes. Oh, so do they do vitamin D in their skin?
Yeah.
Yes.
Oh, that's cool.
Yeah.
My son, I asked my son yesterday, he's 8, whether he remembered someone that he hasn't said they've moved to Victoria 3 years ago. I was like, oh, I saw so-and-so last night. Do you remember them? And he says, I think I do, but they're just in the mist in the back of my brain, so I can't see them. And when people talk about species other than dogs and cats that I haven't studied, or even like things that I know I've studied, but it's like, now that's just going to be my phrase. I can't see it. It's in the mist. Anyway, sorry. So we cover nutritional renal hyperparathyroidism. They're going to have really similar blood test results apart from like PTH and calcium. Apart from, let's just talk about what the ionized calcium is going to look like with chronic renal disease.
I think it's low or normal.
Yeah. Or high.
Oh, yeah. Zero.
It was a trick question. It can go any which way, basically. Why do we see renal hyperparathyroidism? How does that work?
This is the fun one.
Fun one.
It's to do with, I think, hyperphosphatemia.
Mm-hmm.
So that decreases vitamin D production through, I can't remember, it's like FG25 or something, FG23.
Mm-hmm. FG23.
FG23.
The number, yeah.
That decreases vitamin D.
Yeah.
So you get, again, less absorption of calcium from the gut.
Good. Very good. And how does that cause hyperparathyroidism?
Sorry, what was that?
How does it cause hyperparathyroidism?
So again, I think it's less, so I guess it's less absorption of calcium, so hypocalcemia which will feed back on the parathyroid gland, increase parathyroid hormone.
Good.
Which will then increase, try to increase renal retention of calcium, but actually there's more diuresis there, calciuresis. And take it from bone.
Yes, good. So we've lost our ability to regulate calcium absorption from the gut because we've lost our vitamin D regulation. And we've also lost our ability to resorb it from the kidney because of the degree of calciuresis just from diuresis. So we've lost our 2 main kind of regulation abilities. And then the other thing is that we've just lost functional renal tissue. And where is calcidiol converted to calcitriol?
Liver and kidney.
Yeah, where calcidiol to calcitriol is all in the kidney. Cholecalciferol to calcidiol is in the liver. So if you don't have functional renal tissue, you don't have enough vitamin D either. So if you were to measure vitamin D in these patients, is it going to be high or low?
Low.
No, should be low.
Low. Good.
Depends which one you measure.
Sorry. Oh, calcitriol. Yeah, active.
Trial. Low.
Low. Good. What about, that's a really good point. What about if we could measure precursors? That would be really nice. Somebody do a study on calcidiol versus calcitriol in patients with chronic renal failure. There's so many of them. That's a really good study. I'm sure it's been.
We send 25 to America all the time, like every week. Most animals are low.
25 calcidiol?
Yeah.
Really?
Yeah, we do serum. It's like obviously outside of NATO accreditation, but but I follow what the integrative oncologists do in the States because I do a lot of oncology, and so I use the labs that they recommended, and it's generally suboptimal or truly deficient.
Wow. So that is a doable study then if it hasn't been done.
Well, because can you measure calcitriol in Australia?
Someone's working on it, but I don't think you can at the moment. I think Vetnostics have like a trial one coming and going, but
yeah.
Do you know, Josh? Are they doing it at the moment?
No, I don't know. Sorry.
Yeah. Annoying.
Sorry, can I please ask a question? What was Josh talking about the F-22s? They sound like a fighter jet. What were they?
Oh, FG-23. Does sound like a fighter jet, doesn't it? That's that. I can't remember that pathway, but it's a real pain in the ass from memory. Yeah, the phosphate increases that activity to decrease that hydroxylation. Something along those lines. Hopefully, when Anna comes back, she can give more information.
Thank you.
I'm the host now. Apparently,
there's I think it's probably still on the IRIS website because they're talking about it as a treatment paradigm. Yeah, in like calcitriol early and then FGS or FG-23 late renal disease. I feel like I heard about it on the IRIS website.
Thanks, Matt.
Yeah, my pleasure.
Cool.
Have we lost Anna?
Yeah, we just lost Anna, unfortunately. Not sure why.
Should we finish the list of what the Darnit bit is?
Yeah.
Okay, what's that?
Go through the list.
So we're up to H. We're up to D.
Oh, D. So yeah, hypervitaminosis, D.
That's a question for you, Matt. You would have to. I would imagine you would have to have a truckload of vitamin D. Like, is that?
Yeah. It's. I mean, I guess the thing. If you look at like vitamin D toxicosis, where an animal's like presented to ECC having like eaten a whole jar of vitamin D, then yes, that might cause a problem. But generally, like in cancer, I normally have a lot of animals on either 50,000 units a week if it's serious disease, or 1,000 to 4,000 international units per day, which is above the safe upper limit of AFCO. And I normally monitor PTH and calcium and vitamin D if it's within the budget, or you just run the risk depending on how bad the situation is in malignancy. But then when you do the calculations on actually when toxicosis and clinical signs come in, normally it's like mini magnitude higher of international units before you would see that. And I think the thing in humans is like in nursing homes now, they're looking at whether it's appropriate and the best way to do it is actually give old people in nursing homes like 200,000 international units quarterly through the year as a way to just keep their levels high, rather than like dosing daily out due to compliance and budgets, etc. So I think to me, accidental ingestion is obviously real, but there's a big difference between AFCO levels of vitamin D and also and toxicosis. So there's a lot of wiggle room. So and then the other thing I find is that a lot of dogs. I use vitamin D as a marker for inflammation and compare it to CRP and CRP to albumin ratios, and also look at the magnesium level, because magnesium somehow is a cofactor in how it actually gets vitamin D into the body. So yeah, that's sort of my area, I guess.
Thank you.
Now, is there hypervitaminosis D associated with inflammation? Is that a marker for inflammation?
Hypo.
Oh, right. Okay.
Hypo. Yeah. I think so. Yeah, that's what the nutritional medicine textbook, like the human guys, sort of they use it as a target of therapy, not necessarily like a marker. So yeah.
And there's a vegan like omega-3 fatty acid supplement I use, which is an algal origin, which has some vitamin D in it. So I probably don't have to worry too much about that in pets, because it's like, it seems like there's a pretty good margin of error. Like I couldn't find a reliable upper limit for how much you could give to a pet for vitamin D.
Well, it's 75 international units per 1,000 kilocows. That's something like that is the AFCO safe upper limit. But if you just go to the emergency, like an emergency textbook handbook, and look what the toxicosis is, just don't go near that. And I guess it, like, to me, the vegan DHA, microalgal DHA, normally they have D3 derived from lichens, or D2 or lanolin based, which is questionably vegan. I think it's not really a cause for concern. And I guess the thing is, if it sounds a bit roguish, but I guess if you were doing that, but then you saw some calcium dynamics on a blood test, you'd probably go, oh, actually, should we pull back on that? But I think ostensibly it's very low risk.
Yeah, cool, thanks.
Yeah, the big reason why I think the pet food industry has moved to having low vitamin D and being like ultra worried about not going near the safe upper limit is because of the added big scale, the risk of doing a decimal point too high when you're making big batches. Then definitely you can cause problems. But I think it's in practice not probably a cause. Like haven't been doing ECC for 10 years, but essentially, do people see dogs come in sick with vitamin D where it's not accidental?
No.
It's more accidental ingestion.
We're just talking about the incidence of hypervitaminosis D, iatrogenic, without it being a toxicity, like just over supplementation in vitamin, supplementing the pet. Yeah.
Fortunately, most of the supplement, I'm so sorry, you've probably come to the conclusions already, but I'm just jumping in like, what were your conclusions?
We've moved on from gosh. We're on to the D of darn it from gosh.
Okay, well, we've only got 1 minute left. Sorry.
Wow.
So what are the main causes of vitamin D toxicity?
Accidental overdose.
That's all.
The nice thing about the regulation step is that most of the human supplements are cholecalciferol or calcidiol, and it won't actually get converted to calcitriol if it's not needed. So actually the more common toxicities are like psoriasis cream.
Oh, that's right. Yeah.
It gets licked off the owners. So that's like most, the calcitriol is very controlled, prescription only medication, whereas the cholecalciferol and calcidiol not so much.
So the tube of cream, is that the concept?
Yeah, or licking it off their owners. So people with psoriasis put vitamin D on because it decreases the symptoms on their skin, and then if the pets lick them, they get it.
Interesting. Crazy.
And how long would it take to have its effect? When would you see toxicity?
A week or two later.
Yeah, it's like 3 days. If they get a big dose all at once, peaks 3 days after ingestion. And the only significance of that is that in hyperparathyroidism, in the specialist clinic, we manage these patients. And if you take out a nodule and you get hypoparathyroidism and you're relying on calcitriol to correct the calcium, you need to start it 2 days before the surgery. So it's just a nice sort of example.
Interesting.
What's the A? Addison's, good. We'll talk about Addison's in a couple of weeks. Renal disease we've talked about. Nutritional, N was nutritional, isn't it?
Neoplastic.
Yeah, of course. We've talked about that. I,
Idiopathic.
Yep. Let's not talk about that. Sorry, we don't have time. And then T.
Well, in my books, it's temperature, which I guess really goes back to the spurious result. Or do you see it in a fever, or is it related to inflammation? I always put the T. My final exam in memberships was discuss hypercalcemia in the cat. And I was like running out of time, as you do in your last question. So gosh darn it, and wrote everything and then just put T, temperature. I've run out of time, but actually I don't know.
Yeah. I've not had T in any of my acronyms before. I'm not sure how that would impact it.
Okay.
Is that like a malignant hypothermia, like a hypothermia
Maybe.
heat shock thing?
Maybe.
Potentially.
All right. Well, I'm sorry to have missed the punchline, but I'm back now. Next fortnight, I've actually got a conference that starts at 8:30. So I've shuffled around the topics because the next one was supposed to be thyroid disease, which is a long topic. But I've shuffled it around. So we're going to do growth hormone abnormalities just for half an hour in a fortnight. And then the fortnight after that, we'll do thyroid diseases. So I will see you all in 2 weeks. Josh?
And then did you record the last 2 sessions?
Yeah. Have they not gone up on the website?
I don't think so.
Weird. Okay. I'll check that out.
Yeah, we'll get around.
Thank
Yeah.
everyone.
Thanks, guys. Sorry to run over.
Thank you.
Thanks, Anna.
No worries.
Bye.
Bye.
Thank you.